Chapter 30 is covering vulnerable populations. People may be identified as vulnerable for various reasons. They may be victims of intimate partner violence or sexual assault. They may suffer from an eating disorder. They may be victims of human trafficking or identified as members of a sexual minority, such as lesbian, bisexual, or transgender. They may be incarcerated. The members of vulnerable populations often receive poor or infrequent care. They may hesitate to disclose their circumstances and provide healthcare providers with incomplete information that compromises their care. They may not have the resources to complete recommended care and be lost to follow up. Vulnerable patients, like all patients, require respectful care and should be treated with dignity and compassion. Sexual assault is a blanket term used to describe any sexual act performed on another person without that person's consent. The use of force is not necessary to the definition. Instead, a threat of force or the victim's inability to consent is sufficient. Sexual violence is unwanted sexual experiences, unwanted sexual contact, and sexual coercion. Current statistics are staggering. 43.9% of women and 23.4% of men will experience sexual violence over their lifetime. Almost 1 in 5 and 1.7% of men report being raped in their lifetime. Only a small number of sexual assaults are reported to the authorities. Note that mandated reporting varies by state and applies to children, the elderly, and other vulnerable adults. Nurses are mandated reporters, and yet it's the responsibility of the nurse to be familiar with reporting requirements in their practicing state. Ideally, a sexual assault examination should take place within 72 hours of the assault to collect any evidence. Often the person performing this examination is a SANE nurse, or a nurse who has undergone special training to become a sexual assault nurse evaluator. This nurse can then examine the patients, oftentimes in the emergency room. These nurses have specialized training in interviewing and collecting evidence after sexual assault, and their processes are accepted by the state and in courts of law. This nurse is completing what's called a forensic evaluation. They also ensure that the appropriate laboratory testing and prophylactic medications are given to the patient, and then also making sure that they are referred for mental health and victim witness services. It's important that when collecting a sexual assault patient history, that as much as possible the client is allowed to keep their clothing on during the history portion of it and have an advocate or a close friend, family member with them. It is essential for anyone interacting or interviewing this client to take great care to avoid any type of victim blaming or judgment. The history is a critical component of the evaluation of a survivor of sexual assault. It commonly includes topics such as the personal hygiene activities such as the assault, for example, showering or bathing or cleansing of any kind, circumstances of the assault, loss of consciousness or memory, physical descriptions of the assault, specifics of the assault as far as location, condom use, other areas of trauma, and bleeding by the victim or the assailant, and any recent consensual sex that they may have had in the last few days. During the exam, individuals are tested for sexually transmitted infections and pregnancy. Emergency contraception is indicated as soon as possible after an assault within 3 to 5 days. Another at-home pregnancy test should be taken if the client misses a period 2 to 3 weeks after an assault. Female victims of sexual assault who meet the age eligibility requirements should receive the HPV or human papillomavirus vaccine unless it's previously received. Individuals are often tested for hepatitis B immunity, started on the vaccine series, or given a hepatitis B immune globulin if the perpetrator is known to have hepatitis B. If the client has immediately positive results, it's not likely due to the assault. It's usually due to a previous infection. Because of the incubation period, any sort of infection from the actual assault itself is typically not picked up until a little bit later. Treatment is usually given at the time of assaultment prior to receiving a positive result. Risk of contracting chlamydia after sexual assault is 15%, and the risk of contracting gonorrhea is 5%. Because of the high risk of exposure and infrequent follow-up visits, individuals are often treated for gonorrhea and chlamydia after an assault. HIV post-exposure prophylaxis is most effective if started 4 hours after exposure and not effective if it started after 72 hours. PEP consists of medications used to treat HIV and is taken for 28 days. HIV and syphilis testing should be done at 4 to 6 weeks and at 3 months after assault. We should also be very aware as nurses of the sexual assault and the psychological considerations that we should be making. We need to be offering mental health services to all victims of sexual assault. Victims of sexual assault are at risk for post-traumatic stress disorder, depression, insomnia, anorexia, suicidality, as well as a whole host of other emotional traumas. Sexual assault resources for patients can be accessed at RAINN. A wide variety of emotional presentations are possible after sexual assault. Some are very panicked and very agitated. Others are very shut down or indifferent. It does not mean that one way or another a sexual assault has or has not occurred. It just means that each person reacts individually and they all have their own defense mechanisms to help them cope with the trauma of these sort of episodes. It's also important to recognize that those responding or assessing these clients with sexual assault can experience secondary trauma, and to have the support services that everyone needs in place to have a healthy work environment and to help employees and nurses take care of themselves. Human trafficking is a nationwide and worldwide issue. It's also an issue here in Montana. An estimated 21 million people are victims of human trafficking today. 4.5 million are estimated to be commercial sex workers. Human trafficking can be conducted by threat, by coercion, abduction, fraud, or deception. Human trafficking victims face frequent health problems and report seeking the use of healthcare services. 44% report never being offered help from those healthcare services. It's important that if a nurse suspects someone is being trafficked, that they try to interview them separate from anyone else, that they interview them alone to help encourage them to open up. Some victims may not recognize themselves as being human trafficking victims. Others have fear of retribution against themselves, their children, or their families. Unfortunately, patients are not always able to leave the trafficking situation, even once we've identified it. Resources given to them should not be in the form of pamphlets or papers. They should be encouraged to memorize the phone number to the Human Trafficking Hotline, which is 888-3737-888. It's important to talk about some of the red flags that we may see when humans are being trafficked. Oftentimes we're going to see a scripted or inconsistent history, unwillingness or hesitancy to answer questions about the injury or illness. Someone may be unable to provide his or her address or is not aware of their current location, date, or time. Tattoos or other forms of branding, such as property of, for sale, or barcode signs, can be indicators of human trafficking. The client may not have appropriate clothing for the weather or the venue, or is not provided with adequate personal protective equipment for hazardous work for labor trafficking. They may be required to live in housing provided by the employer or have a debt to the employer recruiter that he or she cannot pay off. Oftentimes, victims of human trafficking are accompanied to the healthcare setting by someone who is disproportionately out of age, like an older uncle or an older auntie, who might be controlling, or who the client may be not very talkative in front of, or appear to be afraid of them. When we talk about incarcerated women as a vulnerable population, it's a really large population. Approximately 1.2 million are incarcerated at any given time. All incarcerated women should be tested for pregnancy at the time of incarceration and again 2 weeks later. The expectation is that the care of the pregnant or postpartum incarcerated woman is the same as women who are not incarcerated. Logistics can be a barrier to care, such as transportation, follow-up, and the care of the newborn once it's born. Women who are incarcerated have a higher risk for pregnancy complications. When a woman arrives from an incarceration location like a jail or a prison, nurses should be aware that if they arrive in shackles, this increases their risk for a fall. A corrections officer may be required in the room or just outside the room at all times. There are very few prison populations or jail areas where there's a program offered for women who are having a child while incarcerated. So in most cases, infants are often given to family for kinship care, foster care, or up for adoption. Contraception should be discussed and initiated, and about half of women who are released from incarceration become pregnant again within 3 months. It's also important that women who've just had a baby while incarcerated, that their postpartum follow-up visit is already pre-planned and that appointment is made prior to release. This just helps to avoid a gap in treatment. LGBTQIA plus is an important area to pay attention to when we're talking about vulnerable populations. Caring for sexual minority women, or SMW, may be used to describe a woman who identifies as a lesbian, bisexual, pansexual, transgender, gay, or polyamorous. SMW, sexual minority women, are at increased risk for STIs, substance abuse, and mental health issues. Health disparities in sexual minority women are due to discrimination, stigma, and civil and human rights violations. Lack of disclosure of gender or sexual orientation is associated with higher risk for depression or suicidality. Just as with caring for all humans, when working with sexual minority women, effective communication is key. Try to avoid making judgments, assumptions, gossip, or stereotypes about sexual minority women. Avoid using gendered terms or phrases that pertain to sexual orientation when possible. For example, use the term partner instead of husband, wife, girlfriend, or boyfriend. Use the term patient instead of he or she until or unless the patient's gender identity and preferred pronoun use is clear. Legal documents may not have a transgender individual's preferred name or gender identity. It's common practice for nurses to ask, "How should I address you?" Make sure to ask about gender pronouns. You want to use the preferred gender pronoun, he, she, ze, or they. Respectfully apologize if you've slipped and used the wrong pronoun. Screening that pertains to sexual behavior, sexual preference, and gender identity can help the nurse identify areas for risk reduction, access to services, and appropriate screening or treatments as needed. Genetics, hormone expression, and anatomic characteristics determine an individual's natal, biologic, or anatomic sex. But gender is a construct informed by culture and an individual's perception of self. Gender role is the set of societal expectations placed on individuals on the basis of gender. And gender identity is a person's innate sense of being male, female, or neither. Gender expression is how a person presents to the world, male, female, or neither. Transgender is used to refer to individuals whose gender identity is not the same as their assigned natal sex. An example of what you may see in OB would be a trans man, meaning that that individual was born as a female natal sex and then has transitioned to being a male. Cisgender is when a person's gender identity does align with their assigned natal gender. Genderqueer and gender nonconforming are terms used to refer to individuals of either sex at birth who identify as neither male nor female, but a fluid combination of the two. Gender dysphoria and gender incongruence are terms used to describe the distress or discomfort of an individual's experiences as a result of that individual's gender identity and assigned sex not aligning. Sexual orientation refers to whom a person is attracted to sexually. For our transgender patients at any stage of transition, we can just ask. A transgender male, trans man, female to male, FTM, describes someone assigned female at birth who has a male gender identity. Transgender female, trans woman, or male to female describes someone assigned male at birth who has a female gender identity. They may be in various stages of hormones and surgeries. When approaching kids under the age of 12, when asking gender identity questions, they should be asked of probably a parent or a guardian, as they will often know. Gender identity typically emerges at 2 to 3 years old, and it's okay to start the conversation with parents. At age 13 to 17, we should be asking the patient directly, and we should ask, are they comfortable having any disclosure in their records? Confidentiality, never assume that the family knows. Without these interventions, or without asking, we oftentimes can miss screenings, give less effective counseling, or even worse, have insensitive remarks that go unnoticed. It's important that we ask these questions from our patients, but sometimes we may have patients who are upset about being asked something. And so it's a good standard way of saying, I need to ask these questions. And it just is, we have begun asking all patients about their gender identity and sexual orientation so that we can provide everybody with the very best care possible.
Here are some questions to ask. So we may ask, what is someone's sexual orientation? What are their gender identity? What was their sex assigned at birth? What name would you like us to use? What name is on your insurance records? And what are your pronouns? This is a link to an infographic that is Beyond XX and XY, really looking at the differentiation of sexual determination at the genetic level and giving you lots of kind of information on that. It's very difficult to see in the slide, but if you can at all follow that link to scientificamerican.com, Beyond XX and XY, it's an extremely enlightening article and a great way to learn more about the genetic influences of sex. And that takes us to the end of chapter 30. Have a great day.